Hello everyone from around the world and welcome to this webinar where we're looking at the management of atopic dermatitis in infants with a focus on Pimecrolimus. This webinar has been brought to you by Beatrice. A big hello from me. I'm your moderator, Gemma Boak, a research scientist turned health advocate with a specialist interest in dermatology. We have two presentations for you today. The first is from Professor Carlo Pincelli and the second from Professor Thomas Luger. Professor Pincelli is currently Senior Professor of Dermatology at the Department of Surgical, Medical, Dental and Morphological Sciences at the University of Modena and Reggio, Emilia. He has worked as a clinical scientist for over 35 years and has been the Director of Research at the Laboratory of Cutaneous Biology at the University of Modena and Reggio Emilia for 30 years. He is honorary member of the European Society for Dermatological Research and of the French Society for Dermatology. He recently received the Pro Meritus Award from the European Dermatology Forum for his outstanding contribution to the advancement of dermatology in Europe. Professor Pincelli is also well known for his bench-to-bedside approach. This has led to the discovery of new disease pathways, novel therapeutic targets and drugs. He owns 4 international and 2 national patents. His innovative approach led to the foundation of a startup biotech company, which is devoted to the research and development of new therapies in dermatology. Professor Thomas Luger is Senior Professor at the Faculty of Medicine at the Westphalian Wilhelms University of Münster in Germany. He is particularly interested in inflammatory skin conditions and has authored around 800 scientific publications and is past editor of the Journal of Experimental Dermatology. During his professional career, Professor Luger has received numerous scientific awards and became an honorary member of numerous international dermatological societies. He is a corresponding member of the Austrian Academy of Sciences, a member of the German Academy of Sciences, Leopoldina, and a member of the North Rhine-Westphalian Academy of Sciences. In 2009, he was awarded Doctor Honoris Causa by the Medical School of the University of Athens in Greece. Professor Pincelli will now discuss the need for safe and early treatment in infants affected by atopic dermatitis. If you have any questions during the presentations, we invite you to post them in the question box below, as Professor Pincelli and Professor Luger will be answering them during the Q&A session. With that said, let's get into our topic for today with Professor Carlo Pincelli. Over to you.
First of all, I'd like to thank Gemma Boak for the nice introduction. Today, I will share with you some thoughts and concepts related to the need for an early and safe treatment of atopic dermatitis in infants. What is atopic dermatitis? Atopic dermatitis is a common skin disease and chronic inflammatory dermatosis characterized by eczematous lesions and intense itching. It often occurs in families with atopic disease, including asthma, food allergy, and rhinitis. It has a profound impact on many dimensions on a patient's life. It is associated with anxiety, depression, and the quality of life is very low. It is also associated with a considerable burden for patient's family, the society, and not to mention the economic burden for the healthcare system. The clinical aspects and lesion sites differ according to age. In infancy, the most sensitive areas are affected, including the face, the scalp, and the neck. The worldwide prevalence of atopic dermatitis ranges between 10 and 20% in the pediatric population. The majority of these patients present their symptoms in infancy, with 70% of them are showing the very first signs and symptoms under the age of 2. This underlines the that is of paramount importance to start the treatment as early as possible in these patients. Why the early treatment is essential? Because it prevents aggravation of the disease, it prevents the development of the so-called atopic march, including asthma and food allergy, and also the related comorbidities like the recently reported cardiovascular problems associated with atopic dermatitis. And finally, it decreases the significant burden for the patient, the family, the society, and again, the healthcare system. How do we treat atopic dermatitis in infants? The European guidelines recommend the use of topical corticosteroids as a first-line treatment in infants with mild to moderate atopic dermatitis. However, we all know that the use of topical corticosteroids has several limitations. Topical corticosteroids impair the epidermal barrier function, it induces skin atrophy infections, and also due to systemic absorption, it can affect the growth rate. For all these reasons, there is poor adherence to the therapy with corticosteroids, the so-called corticophobia. On the other hand, we have another class of anti-inflammatory drugs, the so-called topical calcineurin inhibitor, namely Pimecrolimus 1% cream, indicated for mild to moderate atopic dermatitis, tacrolimus 0.03% and 0.1% ointment, indicated for moderate to severe atopic dermatitis. Topical calcineurin inhibitors have several advantages. It has a selective mode of action. It doesn't not impair the skin barrier function, and it doesn't cause atrophy. First of all, we should mention that evidence from clinical trials on the use of topical calcineurin inhibitor have been conducted in infants mostly for Pimecrolimus. Indeed, Pimecrolimus has been approved in many different countries throughout the world, and very recently, EMA approved the use of Pimecrolimus in infants starting at the age of 3 months. European guidelines again recommend the use of Pimecrolimus in the very sensitive areas of the skin like face, scalp, and neck. Talking about selective mode of action and taking into consideration by definition that topical calcineurin inhibitor inhibit the calcineurin-dependent transcription of those genes involved in T-cell activation and cytokine production, several authors have focused their attention on the effect of Pimecrolimus on Langerhans cells. And this cartoon highlights the fact that, unlike tacrolimus and corticosteroids, Pimecrolimus fail to affect density and number of Langerhans cells. More specifically, this is a confocal image where an epidermal sheet was treated with clobetasol propionate, and you see that there is an almost complete depletion of Langerhans cells, whereas the use of Pimecrolimus failed to affect morphology, density, and number of these cells. You may recall that initial safety concerns with Pimecrolimus were mostly related to systemic absorption of this drug with consequent potential systemic adverse events. However, a number of permeation penetration studies has clearly demonstrated that systemic availability of this drug is negligible. In particular, the group of Billick and co-worker has nicely shown that although Pimecrolimus and topical corticosteroids have the same concentration in human skin, the permeation of Pimecrolimus is 100-fold lower than that of topical corticosteroids, likely due to the higher lipophilicity of Pimecrolimus, predicting low systemic exposure. In this study, blood concentration and systemic exposure of topical calcineurin inhibitor, they compared the blood concentration and systemic exposure in patients treated with tacrolimus and patients treated with Pimecrolimus, And as you can see from this graph, the blood concentration and systemic exposure of Pimecrolimus is significantly lower with minimal numbers and concentration for Pimecrolimus. These data have been confirmed in a number of pharmacokinetic studies, all of them clearly demonstrating that Pimecrolimus concentration are always below the limit of quantification. More in detail, these studies show that, for instance, in the first one, patients aged 6 to 12 months have been treated for 1 year intermittently with Pimecrolimus, but no accumulation of Pimecrolimus in blood samples was shown, showing minimal systemic exposure even in the long term. Also, the body surface area did not affect the systemic absorption. Absorption of Pimecrolimus, indeed, there was little difference between the total body surface area affected of 90% and 10%. Also, blood concentration was measured in infants as compared to older children, and we should state that blood concentration was always below the limit of quantification in both groups of children, and indeed, we can say that infants are not at higher risk for systemic exposure of Pimecrolimus. Thus, the use of Pimecrolimus in infants is safe regardless of BSA affected duration of treatment or age. What about the efficacy of Pimecrolimus? Pimecrolimus has been extensively studied in more than 2,000 patients. Here, the take-home message is that Pimecrolimus is efficacious in mild to moderate to severe atopic dermatitis. Again, the detail of these studies, in the first study, for instance, patients were treated for 6 months, twice daily. Application of Pimecrolimus were effective in reducing the risk of flares, 70% in patients treated with Pimecrolimus versus 30% in patients treated with vehicle. In addition, 4 weeks of Pimecrolimus treatment were sufficient to reduce by 70 to 80% the EASI score. What about long-term disease control? After 2 years of intermittent Pimecrolimus treatment, approximately 70% of patients were on remission. What about the rapidity of action? After 4 days of treatment in this study, 40% reduction in EASI score. Given that the most affected areas are the sensitive ones, particularly the face, this study demonstrates that the beneficial effects are exactly the same in the neck area and the rest of the body. What about safety? This is a work conducted on 500 patients, infants treated with Pimecrolimus. The rate of adverse events were similar between patients treated with Pimecrolimus and patients treated with vehicle. There were little side effects, mostly burning and erythema in less than 1% of infants treated with Pimecrolimus, and those were the most frequently observed application site reactions. Finally, consistent with the low systemic absorption of Pimecrolimus, treatment was not associated with immune suppression. What about the long-term safety? Since the implementation of the black box warning back in 2006, a number of studies have focused their attention to evaluate the incidence of adverse events during a long-term use of Pimecrolimus in infants, particularly the 5-year PETIT study and the PEAR study. The 5-year PETIT study showed no difference in growth rate between patients treated with Pimecrolimus and patients treated with vehicle. Secondly, the use of Pimecrolimus did not have any impact on the response to vaccine, particularly tetanus, rubella, diphtheria. And also, very importantly, the use of Pimecrolimus had no impact on the developing immune system, both at the cellular and the immune and the humoral response. PEAR study, on the other hand, is a post-marketing prospective study where patients were treated for 6 weeks, but with an observation follow-up period of 10 years. Well, only 5 malignancies were reported not related to the drug. There were no reported skin cancer in these patients. Therefore, these children exposed to Pimecrolimus are not at higher risk for developing cancer. These 5 epidemiological studies confirm that there is no risk of cancer associated with the use of Pimecrolimus. In particular, you may recall that the major concern was for T-cell lymphoma. Well, all these studies clearly show that there is no increased risk for T-cell lymphoma in patients treated with topical calcineurin inhibitors. In particular, this very nice meta-analysis conducted by the group of Carlo with an extensive review of the literature clearly demonstrated that Pimecrolimus have a favorable safety profile with no recorded risk of increased T-cell lymphoma in these patients. In conclusion, atopic dermatitis is a common skin disorder that particularly affects infants. The possibility of aggravation and of developing the atopic march and related comorbidities require an early and safe intervention. European guidelines recommend the use of Pimecrolimus in sensitive skin areas in these infants. There are numerous studies confirming the safety and the efficacy of Pimecrolimus in infancy, and based on this available evidence, there is general consensus, first of all, that infants with atopic dermatitis should be treated as early as possible, and thus we can conclude that topical Pimecrolimus is a safe and effective and steroid-sparing treatment for infants, and now we can use also in Europe this drug starting at the age of 3 months. Thank you for your kind attention.
Thank you, Professor Pincelli, for your insightful presentation. We now have Professor Thomas Luger, who will be discussing atopic dermatitis from the clinical data to the clinical practice. Professor Luger, I'll now pass the torch on to you.
Dear colleagues, ladies and gentlemen, thank you very much first for your very kind introduction. And what I will do, unfortunately, again, only virtually, to present you a few data on the clinical practice, in particular, in managing infants with atopic dermatitis. This is just to set the stage. Atopic dermatitis is characterized by persisting eczema and severe annoying pruritus. The prevalence is increasing. It's in the range of 15 to 20% in the pediatric population and about 1 to 3% in adults. There is an enormous impairment in the quality of life, mostly due to pruritus. There is an increase in skin infections, particularly with Staph aureus. And recently it turned out that diversity of the skin microbiome, it means all the microbes on our skin, is decreased. If the diversity is decreased, it means that pathological microbes can overgrow and cause infection. There is an association with mental health disorders, anxiety and depression, and comorbidity, including respiratory disease, but also cardiovascular and metabolic disease. There is, unfortunately, still no cure for atopic dermatitis. The patients need a lifelong management with basic therapy, emollients, but also in more severe cases with anti-inflammatory compounds, either topically or systemically. And the treatment targets should include more than one domain. And what I mean by that, On one hand, we have an impairment of the epidermal barrier function. On the other hand, we have an immunodysfunction. It is the most common chronic inflammatory disease in pediatric patients. The prevalence, as already mentioned, is in children in the range of up to 20%. About 90% of atopic dermatitis develops by the age of 5 years. And if we look at the severity, about 10, maybe 40% of the cases are moderate to severe. And again, the infant population is the most relevant, for which an early treatment is crucial. If we look at the natural history of atopic dermatitis, then you see in early infancy, most of the disease develops, it's in the range of 60%. However, if you look at the fate, this is quite different. It might completely disappear and reassume at different ages, or start right at the age of 2 years again. And we have now atopic dermatitis occurring in the elderly population, in 1 to 3%, probably due to the impairment of the epidermal barrier function. Fortunately, most of childhood atopic dermatitis remitted by adulthood. However, in children with already persistent disease, the later onset or more severe disease, they have an increased persistence. Atopic dermatitis is, as briefly mentioned, also associated with other problems. Respiratory disease, for example, allergic rhinitis, asthma, but also with food allergies, emotional contact and hyperactivity problems, but also inflammatory bowel disease, eosinophilic esophagitis, bone, joint, and muscle problems. And again, early treatment at the first signs and symptoms is crucial, and these patients lead a long-term management. And finally, the atopic march. Atopic march means that the skin disease, atopic eczema, and food allergy begin in early infancy and then have a different fate as indicated. Usually, the respiratory disease, asthma and rhinitis, start at a later age. And therefore, it was, I would say, plausible to assume that treating the skin disease effectively in very early infancy could perhaps prevent the development of respiratory disease later on. However, this has not been proven yet. Again, early and long-term treatment of atopic dermatitis might even prevent comorbidity. The burden of disease is enormous. The symptoms, eczema and pruritus, quality of life is decreased, the productivity is decreased. In children, particularly, the school performance may be very poor. The social contacts are disturbed. There is an impact on respiratory disease, and also socioeconomic behaviors are affected. Another issue is the economic burden. And if you look here, the healthcare visits in patients with atopic dermatitis in pink these visits are much more frequent in atopics. The hospitalization is more frequent, and also the emergency room visits. And if you look here in the US, the direct costs are in the range of $1 million plus indirect costs of approximately $3 million, which means a total of $4 million. Now, what do we have as treatment, in particular for mild and moderate atopic dermatitis? I mean, we have emollients and we have anti-inflammatories. And among the anti-inflammatories, since many years, we count on topical corticosteroids. But in view of the novel developments, is there still a need for the use of topical corticosteroids? And this is in particular if you look at the long-term continuous therapy to suppress inflammation. And corticosteroids are not suited for that because the known side effects. And then many patients and caregivers in the range of 80%, they have concerns about prescribing topical corticosteroids. And adherence is also a problem. And about 36% of the patients do not adhere to topical corticosteroid treatment because of the known adverse events. And also many patients and caregivers, they believe that they permeate through the skin and enter the bloodstream, which in some cases indeed might happen. And this highlights actually the need for alternative non-corticosteroid treatments. And if you look at the guidelines, the European guidelines, they recommend in particular topical calcineurin inhibitors for topical long-term management. None of the topical calcineurin inhibitors induces skin atrophy or an impairment of the epidermal barrier function. And this, of course, favors the use over topical corticosteroids for long-term topical management and in particular for sensitive skin areas, delicate bald areas, such as the face, eyelid, anogenital areas, and also infants. Now, a few words on the experience of, in particular, Pimecrolimus in infants. If you look at clinical studies at the beginning, and this is one study involving 125 children treated with Pimecrolimus and compared to 63 patients treated with vehicle. And if we look here, that the mean EASI score, eczema activity and severity index, decreased at 71% in the Pimecrolimus group, but only in the range of 19% in the vehicle group at week 4. In the open label phase, you see a response, a significant response in both groups when they were treated with Pimecrolimus cream. Another annoying symptom is pruritus. And if you look here at day 8, it means that only after 8 days, 70% of these infants had absent or mild pruritus, compared to 36% in the vehicle group. The quality of life is also enormously improved. So already within the first week, 70% of the patients, of the infants, reported an absent or mild pruritus. This was only 50% in the vehicle group. They also experienced a significant improvement in the psychosomatic well-being, social life confidence, medical treatment, emotional coping after only 4 weeks of treatment. And what is also important, the improvements in quality of life of parents were found to be sustained up to 1 year of the treatment. Now, a landmark study, the PERTIT study. It is an enormous, large study involving almost 2,500 pediatric patients, infants. When the study started, they were either 3 or 12 months old. They had mild to moderate atopic dermatitis. The study lasted over 5 years. It was a direct comparison of Pimecrolimus to medium potent topical corticosteroids. It was not a continuous treatment over 5 years. It was an intermittent treatment. Long-term safety was, I think, a crucial issue in this study. and it was a real world design. Now, when we look at the facial IGA, facial involvement investigator global assessment, at week 3, a very quick onset, already 61% were disease-free or almost disease-free. And in the end, it was 95% in the face. And if you compare the two curves, there was equal efficacy in the topical corticosteroid and in the Pimecrolimus group. However, the safety profile, as you will see, of Pimecrolimus is far superior to that of a topical corticosteroid. A similar picture when we look at the overall investigator global assessment, you have 50% at week 3, and at the end, you have about 85%, and again, equal efficacy. When we look at the total body surface area affected, by week 3, it was less than 5% and almost 0 at the end of the study. And again, equal efficacy in both groups. Pimecrolimus also had a significant topical corticosteroid sparing effect. Pimecrolimus treated patients used the topical corticosteroid for a median of only 7 days, compared to 178 days in the topical corticosteroid group. I already mentioned that in this study, the safety was investigated, and this is the antibody titers after vaccination, Elidel group, and topical corticosteroids. And to summarize that briefly, there was no impairment in those infant patients to develop protective antibody titers compared to a normal matched control. Similar data when we look at the cellular immunity, the T lymphocytes, the levels of CD3 positive T cells, and again, the different groups, Pimecrolimus, topical corticosteroids, and the age-matched control. And you clearly can depict there is no difference in the total counts of T lymphocytes. And what is not shown, also the function of these T cells was investigated, for example, looking at the cytokine titers, and there was no difference. So no impairment of cellular immunity upon treatment with Pimecrolimus. The safety overview is summarized on this slide. Of course, I mean, we are talking of an infant population that during a period of 5 years, they have adverse events, most of them not related to the treatment, as nasopharyngitis, pyrexia bronchitis, diarrhea, upper respiratory tract infections, and cough. There was a low discontinuation rate due to adverse events, even lower in the Pimecrolimus group with 0.6% versus 1.1% in the topical corticosteroid group. These adverse events were a little bit higher in the Pimecrolimus group. And this was evaluated as infected eczema. And this was not further differentiated. And it could well be that this kind of infected eczema was also related to the concomitant use of topical corticosteroids. No difference in the growth rates. This was because of the treatment with topical corticosteroids. You would not expect such a side effect with a calcineurin inhibitors, but the typical topical corticosteroid associated side effects were not assessed in this study, such as HbA axis suppression, impairment of the epidermal barrier, masked microbial infections, and aggravation of cutaneous candidiasis or herpes infections. So in conclusion, there was a significant efficacy in infants treated with Pimecrolimus cream. 80% cleared or almost cleared And if you look at the face, was 95%. There was a substantial steroid-sparing effect, no effect on the developing immune system, and most importantly, in this study, involving again 2,500 patients over a period of 5 years, there was no case of lymphoma reported. So in conclusion, the long-term treatment with Pimecrolimus cream is effective and safe. Just one clinical case, an infant, 8 months old, one of my patients, and after discussing with the mother the possibilities for treatment, she agreed to a treatment with Pimecrolimus cream twice a day for 3 weeks, and subsequently to continue the treatment at the first signs and symptoms of eczema and pruritus. And this is the result after 3 weeks. I think it's a very nice result. And in particular, what is important for the child and the family is not crying anymore. There was peace in the family. And finally, and I think these are the very good news, that Pimecrolimus cream is approved for the treatment to mild of moderate atopic dermatitis now in infants from the age of 3 months on. And this is in particular of importance because exactly this population has an enormous high need for an effective treatment. And now I think there is access to this early and effective treatment, which provides, as shown in the study, a rapid and sustained symptom improvement. It prevents the development of comorbidities and decreases the burden on patients and their families. And if you look here again at the map, and this was at the end of last year, the Pimecrolimus cream has been approved also in the European countries for infants from the age of 3 months on. And with this, and actually the Castle of Münster, which harbors the university, I would like to thank you very much for your kind attention.
Thank you, Professor Luger, for your engaging presentation on the application of clinical data to clinical practice. So we are now open for the Q&A session. So if you would like to ask Professor Pincelli or Professor Luger a question, you can use the question box below. And I can see a question coming through now. This is for you, Professor Pincelli. Considering that tacrolimus is also a TCI, why Pimecrolimus should be more suitable to treat atopic dermatitis in infants?
First of all, we should say that the vast majority of clinical studies on topical calcineurin inhibitors and atopic dermatitis have been performed for Pimecrolimus. So most data we know are with Pimecrolimus, and that is why we tend to use this. Although Pimecrolimus has more a approved safety profile and approved efficacy in atopic dermatitis, that's why we tend to use it. And last but not least, it has been approved. Pimecrolimus has been approved for the use of for the treatment of atopic dermatitis in infants in most countries and recently in Europe.
Fantastic, thank you. So, Professor Luger, the next question is for you. What do you think about the use of Pimecrolimus in infants during the period of vaccination? Do you recommend continuing the treatment or advise to take a short break? And if you recommend a break, for how long should it be?
I think this is an important question, actually. And you do not need to stop the treatment. Why? Because there is almost there is no systemic exposure. So as shown already in the Petit study, there is no impairment neither of the humoral nor the cellular immunity. So there's absolutely no need to stop the treatment. And in particular, because you never will do a vaccination on an eczema site where you use an anti-inflammatory drug.
Okay, excellent. Now, this question is for both of you. In a pediatric population, in addition to questions relative to adverse events associated with the active, there can be concerns relative to the excipients. With topical Pimecrolimus, would there be benefit to create an excipient for infants optimized reformulated cream?
Well, of course, you could in a way optimize the emollient used for Pimecrolimus cream, and this also applies for tacrolimus. But the problem is it's very sensitive, and the development of a suitable emollient which does not trap the drug was very difficult. And I personally think that the formulation of Pimecrolimus cream is already, to say so, very good. Also, in particular, for sensitive skin and also for infants. One of the advantages over a greasy ointment is that you do not have this occlusive effect, which particular during the summertime or in hot and humid climate might cause problems.
I totally agree with Professor Luger's statement, and of course, we have so many patients already treated with Pimecrolimus, and they are very happy with that kind of formulation, particularly, as Professor Luger said, on the sensitive areas. So I think we need to continue with this kind of formulation.
Excellent. Professor Pincelli, what is your experience regarding the safety of Pimecrolimus in infants, and particularly related to lymphoma risk?
Of course, my personal experience is very good, but I have also to rely on the high numbers we find in the literature. But in my personal experience is very good. I've never had any case of T-cell lymphoma. One thing we should state here is that probably nobody knows that atopic dermatitis in general is associated with increased risk of T-cell lymphoma. But despite that, most of the studies have clearly shown that there is no increased risk of T-cell lymphoma in patients treated with Pimecrolimus in any of the studies, and also in the very nice meta-analysis I showed from the group of Professor Paul, who clearly did an extensive studies of the literature showing very clearly that there is no risk associated with the use of Pimecrolimus in infants. So it's not just my small experience in my a small university or hospital, but it's the experience from most of the studies all over the world.
Actually, I fully agree with what Professor Pincelli says, and I just want to add something to that we are using now these topical calcineurin inhibitors and Pimecrolimus for a period over 20 years. And over this period, of course, the development of lymphoma, in particular in children and infants, has monitored very, very closely. And from this data, I can absolutely say there is absolutely no evidence, not a small sign, that the use of Pimecrolimus would increase the risk of developing lymphoma. And looking also at the Petit study, over 5 years, there were among 1,200 patients treated with Pimecrolimus. And in this study, no case of lymphoma occurred.
Thank you for the additional input. That was really interesting. Thank you. This next question is for both. For 3-month infant with atopic dermatitis, can we start with Pimecrolimus without topical corticosteroids?
I should say yes. First of all, because it has been approved for starting exactly at the age of 3 months, and secondly, because it is as it has been shown as effective as topical corticosteroids in terms of efficacy. It doesn't affect the barrier, which is a very important point. Unlike corticosteroids, it doesn't cause atrophy of the skin. So definitely, I would start myself with Pimecrolimus without any doubt.
Professor Luger?
I completely agree with that.
Okay. Let's see. Professor Luger, how to prevent burning after Pimecrolimus application?
I think this is also an important issue. And interestingly, it mostly affects the more the adolescent and adult population, not so much the pediatric population. However, there are several ways to prevent it. One very simple way is to put the tube with the cream in the fridge before using it. This can be explained by a mechanism on certain ion channels on nerves, which are in a way, to put it in a very simple way, silenced by cold. And in many cases, this works. The other thing is, what you also can do, use intermittently at the beginning a topical corticosteroid, a mid-potent topical corticosteroids. You will not need to use it for a long term. It is usually enough for 2 or 3 days. And in adults, you also can use acetylic salicylic acid, 1 tablet, 1 hour before the treatment. Again, not for the whole period, only for the first 2 to 3 days.
Okay. Professor Pincelli, to what extent do you worry about the potential impact on the skin microbiome from the Pimecrolimus formulation?
Unfortunately, I don't think there are many studies on this. I don't know whether Professor Luger has personal experience and input on this way, but personally, I don't think it should be a major problem. I mean, it is a problem in general for the pathogenesis of atopic dermatitis, but I don't think that Pimecrolimus would interfere with this to a major extent. I don't know what Professor Luger thinks about this.
No, Professor Pincelli, you're absolutely right. And the available literature is rather sparse, but I mean, there's some data for a calcineurin inhibitors, more data about the topical corticosteroids. And actually, this does not impair the diversity of the microbiome, which is important. On the contrary, we see an increased and normalization of the diversity of the microbiome, and also a decrease in the pathogenic Staph aureus. This in particular has been shown very clearly for the treatment with topical corticosteroids.
Ooh, the next one, I'm very interested to hear your thoughts. So this is a question for both of you. I don't know if you want to go first, Professor Luger. Corticophobia, how can we manage it? Do you suggest counselling the patient or just change the treatment?
Who wants to start?
I think I nominated you, but I'll let Professor Pincelli go first if he wants to.
Well, I mean, this is an increasing problem, the corticophobia, and it is mostly due to the social media and lay press, which report side effects of corticosteroids, and mostly due to the side effects of a systemic treatment with a topical corticosteroid. And the corticophobia is increasing, and well, I think sometimes it's worthwhile talking to the patient, talking to the mother of the patient, counseling them. But if this is a fixed idea of those patients, there's no way. I mean, you can try to persuade them, but then they will go to another doctor, and they will do this doctor hopping.
I mean, corticophobia has been around for many years. I think I would say since I started my practice, actually, because we have always had to deal with mothers, even adults. They don't want to have any steroid therapy, not to mention the systemic administration of corticosteroids, of course. So I agree with Professor Luger. You cannot sometimes convince mothers about this, but I do a lot of chatting with them sometimes, and if I don't convince them, then of course I can move. And luckily enough, now we have Pimecrolimus in our hands that we can where we can replace steroids with this very effective treatment. So we don't have to deal with corticophobia at least as much as before. Let's say.
Right.
Fantastic. So this is another question for both of you. Are there studies investigating Pimecrolimus absorption on the scalp, increased absorption via hair follicles?
Not that I know of, honestly.
No, this is right. I mean, there are no studies actually investigating that, but in an indirect way, I can answer to that, because there are at least several case reports on patients with Netherton syndrome, which have a significantly impaired barrier function. And we also treated some of these patients and monitored systemic exposure after treatment with Pimecrolimus cream. And what was amazing, you had very low levels after 2 weeks of treatment, but after 4 weeks of treatment, and even those were children, after 4 weeks of treatment of the whole body, there were no detectable Pimecrolimus levels anymore. So I would say, if you apply that on the scalp, it's not approved for any scalp disease, I think there's absolutely no risk that you will end up with considerable systemic exposure.
Okay, and another question for both of you. To treat infants, which would you use first between emollients and Pimecrolimus? And which should be the time, what should be the time between the two applications?
Yeah, of course, that really depends on the severity of the disease at that time when we make this choice. And a very important point is that there are studies showing that treating atopic dermatitis in infants with emollients alone does not prevent the comorbidities, food allergy, atopic mark, that has been shown very clearly. So, except for those very mild cases, I think we should go for Pimecrolimus, and hopefully, although it is not like Professor Luger mentioned in his talk, it's not, there's not clear evidence for that, but hopefully we can better prevent the development of atopic march and other comorbidities.
Yeah. Yes, I also agree. I mean, I would start definitely first with Pimecrolimus cream, with the anti-inflammatory compound, which relieves the symptoms, not only eczema, but also pruritus. And this is something you need in any patient, and in particular in infants. And then subsequently, I mean, if the skin is still very dry and needs an emollient, then you can additionally use emollients afterwards. The time span in between should be between 20 and 30 minutes, because you should not mix an emollient with Pimecrolimus cream because of the particular texture of Pimecrolimus cream.
Okay, the next question is also for both of you. What are your thoughts on switching a patient from topical corticosteroids to Pimecrolimus? Would you recommend to gradually taper topical corticosteroids over time, or stop and start straight with Pimecrolimus?
Thomas?
Okay, this really depends on the severity of the disease. Usually, if I have a case with moderate atopic dermatitis, I would start with a topical corticosteroids for the first couple of days, let's say 3-4 days, and then switch to Pimecrolimus cream. I would do it. I do it in that way that I taper off the steroid. So it means because you apply both drugs twice a day. So after 3-4 days, I say once a day topical corticosteroids and once a day the Pimecrolimus cream. And then usually after a few days, 1 week or so, you can completely switch to Pimecrolimus cream. However, I mean, there might some cases, and we were talking about corticophobia. And I remember one of my patients, a young girl, who had, I would say, moderate atopic dermatitis, in particular in the head, in the face and neck area. And I proposed this type of treatment, and she absolutely denied. She said, I don't want to use a topical corticosteroid anymore. So I said, okay, let's try it, and started her with Pimecrolimus cream twice a day. And after a few days, after 1 week, there was a nice improvement using Pimecrolimus cream as a monotherapy.
Yeah, I would do exactly the same, and of course you need to taper corticosteroids, particularly if you have been using it for quite a number of days. I mean, if it is only 2 or 3 days, then you can switch it with Pimecrolimus right away without even tapering that.
Okay, so another question for both. For country with our population are not well aware of the side effects of corticosteroids, do you think it is a good idea to increase the awareness of these side effects to the public?
I would say that there is even, like Professor Luger mentioned before, there is even too much awareness about the topical side effects of corticosteroids. It's just the opposite. I mean, of course, we need to speak with the patient to explain to them, and particularly the parents, the side effects, but they know already. Of course, they don't know specifically the side effects. They know in general that steroids harm, but you know, then you have to go maybe into details just to, let's say, have their approval, let's say. But I would say that there is too much information. Maybe we have to correct that information, which comes through the social media, through internet. We have to correct it, of course, just by explaining in detail which are the pros and cons of the use of corticosteroids.
I absolutely agree.
And then this is the last question. So, do you expect the next version of the EU guidelines will be updated with this new indication? So this is a question for both of you. I don't know if you want to go first, Professor Luger?
Yes, I know. The EU guidelines will update this, and this will be included in the novel version of the EU guidelines.
Yeah.
Excellent. Thank you very much. Is there anything either of you would like to add before we end?
Just thank everybody.
Yeah, thank you to you, Gemma, and to all the audience and the people who were so nice to listen to our presentations and to participate in this this webinar. Thank
you. So this concludes today's discussion. This project was funded by Medipharma SPA, a Viatris company. Thank you, Professor Luger and Professor Pincelli, for joining us today and sharing your insights around the management of atopic dermatitis in infants. Thank you to the EMJ for facilitating the discussion. Finally, I want to thank you, our audience, for taking the time to participate and for your interesting questions.
Thank you.
Thank you.
Thank you.